us, Dr. Hata. He's an emergency medicine attending here at CMC, and he's also director of the Operational and Disaster Medicine program here. He actually sits on the board of directors of the World Association of Disaster and Emergency Medicine, so I'm sure that'll play in to his talk a little bit today, and he's going to talk to us about disaster medicine, and unfortunately, this is probably nearer and closer to the real world than we'd like to think, but cyber disaster medicine. So, Dr. Hata, take it away. Thanks for being here. Really look forward to your talk.
Great, thank you. Can you guys see my screen now? Do you see the big world?
Yes, we can.
Great. Okay, perfect. Well, sorry for the technical issues, but hopefully this will all work out. We do have video. If it doesn't play, then that's fine. We can just move on. But thank you so much for joining me on this talk. It's a pleasure to be here. This is the first time that I've actually been part of the MTAC organization. I haven't, unfortunately, wasn't able to attend the recent regional meeting, but really have been following this group, and it's doing some great stuff. So I'd like to start out by talking about or looking back in history a little bit. So in 2017, the world underwent a pretty bad ransomware crypto worm called WannaCry. And some of you may have been practicing during this time. It was one of the worst cyber attacks that ever hit the world. And unfortunately, much of the healthcare system was unprepared for this. It affected many different organizations and many different countries. It affected the United Kingdom, Russia, Ukraine, Taiwan, and several other countries, as well as many industries. However, most people remember it for the impact it had on the National Health Service in England. It affected over 300,000 computers in 150 countries, and it ground the National Health Service to a halt. It's very difficult to know the clinical impacts, but we do know that it cost hundreds of millions of dollars, potentially billions of dollars, and the impacts are still being felt today. This was released, most people think, by the North Koreans. However, it was actually invented, this crypto worm was invented by the National Security Agency in the United States of America. It was subsequently stolen by a hacker group and then obtained by North Korea and released into the wild. And this introduced many people in the world to the idea of cyber disasters or international cyber attacks, and this idea of asymmetrical conflict and hybrid warfare in areas where we thought previously were sort of untouchable, things like healthcare and public health. So again, my name is Ryan Hata. I'm an emergency medicine doctor by training, and so I primarily work clinically in the emergency department at Carolinas Medical Center here in North Carolina, although I have been studying healthcare cybersecurity and cyber disaster medicine for the past several years. And this is sort of a new emerging field and rapidly evolving field, and a subset of disaster medicine, which is my kind of overall academic focus. I have no disclosures and no conflicts of interest. And I want to start by thinking about sort of intentional attacks. So when we think of intentional attacks, we often think of things like mass shootings. We may think of classic sort of terrorism, like bombings or, other types of terrorist attacks. We may think of intentional conflicts or conflicts between nation states or non-nation states and nation states, such as what's occurring in Ukraine currently or in the Middle East. But when we look at a picture like this, how many of us think about an impending attack or a potential vulnerability? This is something that we see almost every day. In fact, I would say every day in the hospital, in the clinics. I am guilty of this, as just like everybody. But how many of us, when we see this type of a very innocuous, benign looking image, think that this may be a vulnerability into our systems and may actually generate a catastrophic cyber attack? What about this type of a device? We rely on these devices every single day for the care of our patients. These are integral to our healthcare delivery. And it's not just medication delivery pumps. It's all the different integrated medical Internet of Things or Internet of Medical Things or Internet of Things that we use every day that are connected to various networks to deliver care. But how many of us think of these as being vulnerable and possible avenues of infiltration. Often these types of devices, especially our legacy devices or older devices, are not patched. They may be operating on older operating systems. The security is often quite poor in these types of devices. They're not designed to be secure, and yet we use these on a day in and day out basis to function and to carry on life-saving interventions and care. So this is a brief sort of overview. This is called Zero Day. This is a trailer for this documentary, and I would highly recommend everybody watch this documentary. There's another one on Netflix called Zero Day, not Zero Days. I think that's a drama, but it's also about sort of cybersecurity and cyber attacks. But this is a documentary about the Stuxnet virus. That was the first cyber offensive virus, or first cyber offensive operation that was conducted back in the early 2000s. And this was not just a cyber attack. This was what's called a cyberkinetic attack, which we'll talk a little bit more about in a little bit further down the presentation. And this is where the United States, in conjunction with Israel, conducted an operation where they attacked the centrifuges of the Iranian nuclear program. So if we can get this video to work, it's a pretty interesting documentary. If you haven't watched it, I would highly recommend it. Okay, it's not working. So anyway, basically, this sort of talks about, or this documentary goes over how incredibly vulnerable all systems were, and that this virus, the Stuxnet virus, was not designed for any one particular, or it was designed for one particular purpose. However, it utilized a vulnerability in a Windows operating system that was used ubiquitously across the world. And in fact, it wasn't just the Iranian nuclear centrifuges that were infected, but many, many systems around the world were infected by this virus, but it didn't actually cause any damage. What it did was cause the centrifuges to malfunction and then eventually collapse and explode. So it was utilized as not only a way to disrupt their systems, but actually to physically damage their critical infrastructure in their nuclear development program. So how bad is this problem in healthcare? Well, it's pretty bad. We all, I think, know that. I think it's pretty obvious. Most people that have been in practice for a while understand just how serious these attacks are. And in fact, I would bet many people on this call have unfortunately been part of or been adjacent to a health system or an entity that's been attacked. In fact, I can almost guarantee that if you've been in healthcare in the past 2 years, that you've been impacted simply because of the Change Healthcare attack. Well, this is a study that we looked at a couple of years ago that looked at 11 years of data on data breaches. These are healthcare data breaches in particular. And what this is looking at is the number of data breaches that affected 500 individuals or more. And what you can see here is from 2011 to 2021, we had a fairly significant increase. There was a little bit of a dip in 2015, which is interesting, and I'll show you that on the next slide. But we had this sort of dip, but then it has a steady rise. And if you were to extrapolate this out further into 2026, you would see a pretty significant increase, especially in 2024 with the Change Healthcare data breach. But I don't want to just talk about how this seems to be an increasing problem, although it is. What I want to do is talk about how in 2021 there was another crisis that many of us lived through called COVID-19. I'm sure everybody remembers it. And I'm not trying to say that COVID-19 caused more cyber attacks or cyber attacks were in and of themselves related to COVID-19, because I think that's very difficult to prove. What I want to bring to people's attention is the idea of a polycrisis or multiple crises hitting simultaneously. So in the midst of a global pandemic that had disrupted the world, all of a sudden we start to see more cyber attacks, which create this polycrisis situation where people are dealing with not one, but potentially two or more simultaneous crises. How does an organization, how do clinicians deal with these simultaneous crises? That is something that we're going to talk about, and it is unfortunately a wicked problem that's very difficult to solve. In the same study, we looked at the number of individuals that were affected in this 11-year period, and year by year, you kind of see this sort of seesaw pattern. But look at 2015. We had mentioned in the previous slide that even though the number of cyber attacks or the number of healthcare data breaches during that time seemed to be low, the number of affected individuals is actually by far and away the highest. And again, if you were to extrapolate this out, that number would literally be off the charts if you were to look at the Change Healthcare data breach. But what happened in 2015 was that we know that there wasn't an increase in the number of data breaches. What happened in 2015 was the Anthem data breach, which some of us may remember. This compromised the PHI, or the protected health information, and the PII, the personally identifiable information, of over 78.8 million individuals in the United States. And in fact, up until that time was the largest healthcare data breach the Change Healthcare data breach was the largest healthcare data breach up at that time. So you can see that one data breach, one cyber attack can have a disproportionate effect on individuals and regions, as well as even on an entire nation. Again, we'll talk about that with the Change Healthcare data breach. So looking at this study and looking at some of this data, we realize that that cyber attacks are not often found in isolation, but may be part of a polycrisis situation, and that one attack can disproportionately affect individuals and organizations. So why are these things occurring? I think it's pretty obvious. The most obvious reason really is money. The attackers, by far and away, the vast majority of them are doing this for financial gain. Most of these are cyber criminal gangs that are located overseas, although there is increasing evidence to suggest that that many of these attacks are originating from within organizations, so they're actually internally motivated, and that could be due to disgruntled employees trying to hold their own organization to ransom. But also increasingly, I think we're going to start seeing nation states or quasi-nation state actors or actors that are backed by nation state resources attacking healthcare entities because, unfortunately, we are a soft target. And with the increasing hybrid warfare and asymmetrical conflict landscape, this is something that we unfortunately need to be more prepared for. Healthcare had the highest average data breach cost of any industry in 2020, and that number has pretty much stayed the same. It has been at the top or near the top over the past 6 years. The average ransomware demand in 2021, I believe it was $4.6 million, and that stayed about the same. The most recent data that I read, that the average ransomware payout was $4.4 million in 2025. And then the average cost of a healthcare data breach was $10.1 million in 2022, and that has stayed about the same. I believe that number has gone up. So you can see these are unfortunately very expensive endeavors for hospitals if you are attacked. And why, again, are hospitals attacked? Well, it's not just because of the money and the payout, but we as healthcare providers and hospitals and health systems are not only early adopters of technology, but we're also very heavy users. So look at this picture of a typical operating room in the United States. This could also be a trauma bay. This could be any hospital in the entire country. And how many connected devices do we see? We have patient monitoring devices, medication delivery devices, PACS machines, EHRs. What about the patient themselves? They may have connected devices. What about if they have an AICD that's connected, or a medication delivery pump like an insulin pump? What about the clinicians, the doctors, the nurses, the technicians? All of them have on smartwatches, maybe an Oura Ring, a cell phone. So in this one picture, you can see there may be dozens or even hundreds of devices connected along multiple different networks. And so this creates a very, very broad and deep threat landscape, or basically attack surface. It's kind of what it's called. So we have a very, very big attack surface in healthcare, which makes us more vulnerable, because we know that connectivity equals vulnerability. So the more connections you have, the more networks you have, the more devices that you have, the more vulnerabilities that you're going to have within that system. Excuse me. So now I want to talk we've talked a little bit about sort of the threat landscape. We've talked about the attack surface. Now I want to talk about some specific types of cybersecurity issues or cyber attacks that occur in healthcare. And there are many different types of cyber attacks. I don't want to talk about all of them, it'd take forever. But these are just some basic types of cyber attacks, things that we should be aware of. Some of them you've probably heard of, and others you may not have heard of. So the first is a ransomware attack. I think we all, at this point, hopefully understand what a ransomware attack is. If you don't, it's where the threat actor, the nefarious individuals, will infiltrate your systems through some type of vulnerability, maybe a phishing scam or a vishing scam, or maybe they find some device, they infiltrate through a device or a vulnerability in a software, and then they map that software, and they'll stay dormant, often for weeks to even months, as they sort of move laterally across systems, escalate privileges, and then begin to map the entire network. Then they'll deploy encryption software. Often this is military-grade encryption software, and then they'll extort you or your organization for perhaps millions and millions of dollars. If you decide to pay that extortion, they will, say they'll restore your systems, but often the systems are corrupted. They may be, their data has almost for sure been stolen. And then you may be the victim of what's called a double or triple ransomware attack, whereby the attacker will use that stolen data and threaten to sell it on the dark web, or they may actually sell it. And if they'll threaten to sell it, and if you don't give them more money, they'll sell it on the dark web. They'll probably sell it anyway. And then they may mine that data for high value individuals with compromising information. Say, hello, Mr. Doctor so and so, or Mr. Or Mrs. Administrator. You have, you saw a psychiatrist, or you have this disease or this medical problem that you're not telling people. We're going to release that to your significant other, or maybe to your employer, or put it out publicly if you don't pay us another ransom. So you can see that it's not just the simple ransom that is often demanded by the organization, but this may lead to several sort of subsequent ransom attacks. And we know these are increasing. In fact, the HIPAA Journal just published this, that there was a 49% year-over-year increase in disclosed ransomware attacks. And unfortunately, many health systems do not disclose if they've been a victim of a ransomware attack. They simply say that they're having an extended downtime, and then don't go into any type of detail. And there's a 37% year-over-year increase in undisclosed ransomware attacks on healthcare. So again, this problem is unfortunately increasing. The other type of attack is a data breach or a data theft. We talked about that with the Anthem data breach. This may not be a health delivery organization like a hospital. This may be a healthcare adjacent organization, such as an insurance company or a device company or something like that, where they steal the data and then they either sell it on the dark web, because healthcare data does have value on the dark web, or they may use it in an extortion attempt as well. The third type is a device hack, they'll hack into your systems and then take control. And this is called a hijacking, like a session hijacking or a device hijacking. And this is not really, we haven't really seen this in healthcare. There really haven't been any cases that I'm aware of this actually occurring. It'd be extremely damaging if it did. But we do know it is certainly possible. In fact, this was research done by individuals at the University of Ben Gurion in Israel. And what they did in this particular study is they took the medical image on the left there, which is the true image. This is a CT scan of a woman who'd had breast cancer, mastectomy, and was undergoing a surveillance scan. They were able to hack into the PACS machine and change that image to the one on the right, which is very concerning for widely metastatic disease. We also know the FDA has put out several warnings about medication delivery pumps that have backdoors that are built in and could be infiltrated, and this could deliver erroneous doses of medication to your patient. So again, while this has not been seen, this is very, very concerning as a potential avenue of cyber attack, especially against high-value targets or important individuals. And then the last thing I just want to talk about is a healthcare supply chain cyber attack. And most people are not really aware of this. Sort of the best example I can use of a supply chain attack is the pager attack on Hezbollah that was carried out by the Israelis 2 years ago. In this, if you're not familiar with this, the Israeli military and the Mossad, which is sort of their version of the CIA, they infiltrated the manufacturers of the pagers and walkie-talkies that were being used by Hezbollah in Lebanon. And they were able to put explosives in those, and they were able to manipulate the electronics. And then at a certain point, they detonated those explosives, killing and injuring many individuals. That is another example of a cyberkinetic attack. But in healthcare, we often don't really look at our supply chain. We don't have, studies have shown that we really don't have a very good vetting process. In fact, in this recent study by the Poneman Institute from 2023, only 19% of organizations had a complete inventory of their current supplies, and only 44% of respondents conducted security evaluations of suppliers who are business critical. So this is one of the avenues in which nefarious actors or cyber attackers will try to infiltrate into organizations, and healthcare is particularly vulnerable because we have such a deep and wide supply chain. So again, we've now sort of gone over the threat landscape. We've talked about attack surface. We've talked about the different types of cyber attacks. Well, I'm not trying to scare people. I'm just trying to set the stage so that we understand the problem and sort of the mindset of the individuals that are conducting these types of attacks. Well, how do they impact us operationally? And then we're going to move into sort of some of the potential solutions to this. Although I'll be very honest, they're not great solutions. If there were, this probably wouldn't be such a bad problem. So we know that ransomware attacks particularly are extremely disruptive operationally. And I'm sure there are people on this call that have been part of a ransomware attack, or at least been involved with a hospital or health system that's undergone a ransomware attack, and understand just how disruptive these things can be. This is a very interesting study done in 2020 out of the University of Vermont. When they underwent a cyber attack, they underwent a ransomware attack starting on October 28th, and it ended on November 22nd. So you can see these two graphs. On the left, this is their daily chemotherapy infusion visit volume, and on the right, this is their daily clinical outpatient and telehealth delivery volume. And what you see on the left, that graph, is that they were averaging about 35 visits per day, and the day after the cyber attack, they went down to 5. So it completely disrupted their ability to deliver critical care, chemotherapy to these cancer patients. And while they did have some element of recovery, they had a 52% decrease in ability to deliver this type of critical intervention to these very sick patients over the duration of that cyber attack, which is between those two red bars. On the right, you see the clinical outpatient delivery and telehealth volume had a similar decrease immediately after the attack. It was about 40% decrease in ability to deliver outpatient care. And that, of course, is in that pink box there. That's the time of the cyber attack. But we know that this is going to happen during a ransomware attack. But what I'd like to bring your attention to in these two graphs, and we'll look at this in a couple of other graphs as well, is what happens after the end of the cyber attack. It doesn't immediately go back up to normal. Operations lag. In other words, the operational capacity and capabilities of an institution lag generally about 2 to 4 weeks. And you can see that as far as their chemotherapy infusion visit volume, that did not actually go back up to pre-attack numbers until January of the next year. So they had a good month to month and a half of compromised delivery, and the same thing was true for their outpatient volume. So again, there's sort of this lag or delay effect on the back end of these ransomware attacks.
He's at the point where should be transitioning.
Okay.
You guys there? Okay. So we also know that it not only disrupts operations within one facility, but it also disrupts operations regionally. So if one hospital is attacked or one health system is attacked, it can have significant impacts on outpatient delivery, even pharmacy and adjacent healthcare, EMS systems, and of course, other hospitals in the region. In fact, this was seen in the Ascension Healthcare cyber attack in 2024, which occurred from sort of at the end of May, beginning of June, all the way up until July of 2024, that affected over 140 hospitals across the country. We know that care was compromised, and in this particular case, what we looked at was in our region looking at EMS volume across different hospitals. And to kind of explain these two graphs, the top graph is all hospitals that were not undergoing a ransomware attack, and the bottom graph was the Ascension St. Vincent Hospital in our region that was undergoing the cyber attack. And this red box, that is the time. That's the time of the attack. And what you see in the squiggly lines is the blue line represents 2024, which is the year of the attack, and the red line is 2023, which is our control. And then we looked at the 30 days before and 30 days after, and as our second controls. And so we were able to compare not only year over year, but also across multiple months. And what you see on the top graph is right after the cyber attack occurred, you see this massive spike in the blue line. That's the 2024 EMS volume. So all other hospitals had a massive spike. And of course, you see an exact mirror in the St. Vincent's where they had to go into diversion. They had virtually no EMS during that first week or so after the attack. You see this, it sort of comes back to normal in the middle, and then it has another subsequent spike. And that is something that usually what will happen is after the hospital goes on diversion, they'll try and regain normal operations, but then a week or two later, they realize that it's so difficult they will go back on diversion, and that's what happened in this case. And I know because I was working at one of the hospitals that was close, and I can tell you that we got hammered with EMS the day of that, the day and the day after that attack. So, and it lasted for about a week. And so not only does it disrupt EMS systems, but we also know that it disrupts emergency departments as well as inpatient and surgical services as well. So this is a study that was done out of the University of California in San Diego during the Scripps ransomware attack back in, I believe, 2021. And you see it was a similar methodology where they looked before, during, and after the attack. And during the attack, you can see that they had sort of the spike in ED census and primarily their incomplete care delivery per day. And it may have just been that those were really busy days, that it just happened to coincide with that cyber attack. But they did have an increase in their inability to deliver care and incomplete care. So they had a higher left without being seen rate during that time. They also looked at the EMS diversion hours and saw that they had obviously a huge spike in diversion during the first week to week and a half of that cyber attack. And again, I believe I'd have to go back and look, but I think the cyber attack only lasted about 1 to 2 weeks, maybe. And then you sort of see that lag again in week 7, 8, and 9 there, where the hospital is still trying to recover from the effects of this attack. This is an interesting case study out of Lubbock, Texas, and the University Medical Center there is the only level 1 trauma center within 400 miles, and they underwent an attack in September of 2024. And patients had to be diverted up to 400 miles away during this attack. So this brings up another very interesting concept. So we looked at the other two examples, the Ascension and the Scripps example, and what I didn't mention, but what I want to talk about is there's this idea of a cyber blast radius. So if one health system is affected, it has disproportionate effects on multiple different health systems and adjacent healthcare delivery organizations in a region. However, if your organization is in a rural area or is the sole provider or one of the sole providers of care in that region, it not only has a cyber blast radius that can be huge, but it then creates a care vacuum in that area. So no longer are you able to deliver specialized care. So this trauma center unfortunately had to go on diversion, and all of these critical trauma patients had to be diverted several hundred miles away. So it can be quite challenging in this situation. This also happened in Chicago during the Lurie Children's Hospital was hit with a cyber attack, a ransomware attack. And luckily in Chicago and in the adjacent area, there are several other care facilities. But if this had happened, say, at Riley Children's Hospital in Indianapolis, where I was working before, there's no children's hospital within probably 100, 150 miles. There's one sort of in the city, but it doesn't have the capacity to care for all of the sick children that were being cared for at the hospital in Indianapolis where I was working. And so those children would have had to been sent to Chicago, St. Louis, Cincinnati, Louisville, Kentucky, and it would have been very, very difficult to maintain good care, especially when you combine this with the idea of compromised outpatient care, compromised critical care, lack of medical records, not being able to transfer medical records and imaging and all of the things that we rely on. So we've talked about the cyber blast radius, and we've talked about now care vacuum. The next thing I want to bring up is how one institution or one organization that's hit can affect multiple different adjacent organizations across the country. So the United Health Change Healthcare ransomware and data breach was the largest data breach in the US history. It was absolutely devastating. In February of 2024, Change Healthcare underwent a ransomware attack. They process 1 in 3 claims in the United States, billions of claims. They interact with almost every major healthcare organization in the country. And they were compromised significantly with this ransomware attack. And this not only impacted their organization, but it impacted almost every single health system in the country. Anybody who was interacting with Change Healthcare could not get their processes, their claims processed. And so payments basically were not able to be done at multiple health organizations. Also, pharmacies were not able to process prescriptions, and so patients were not able to pick up their medications. So again, it wasn't a healthcare delivery organization that was hit. It was an adjacent business that processes the claims, yet it was incredibly disruptive and very expensive. You can see there were $14 billion in medical claims backlogged during this attack. And the attack, their estimates, I don't think anybody knows for sure, but their estimates of over $2.5 billion in damages and costs to United Healthcare. In fact, it was so disruptive that the American Medical Association put this statement out in April. So the attack occurred from the end of February kind of through March. And a month later, 60% of providers were unable to or were facing challenges in verifying patient eligibility. 75% still faced barriers with claim submission. Up to 80% could not receive electronic remittance, and 85% experienced disruptions in claim payments. And this statement by the AMA president is pretty important, that the survey data show that practices will close because of this incident, and the patients will lose access to their physicians. Again, this was not a health delivery organization that was attacked, yet it had such a profound impact on the healthcare system in the United States that doctors' offices were having to close. And I know the health organization where I worked, I talked to the CISO, which is the Chief Information Security Officer, about this, that we were not in bad shape, but it was getting to the point where they were having to get into some of their emergency funds, and that other healthcare organizations that were in that same region were not able to pay their clinicians, their staff, because they just could not process any of these claims. And the last thing I want to talk about is adjacent critical infrastructure. Again, I'm not trying to scare people. I'm just trying to set the stage for how complex this problem really is. So we know that just even this month, it's been reported that the IRGC potentially attacked water treatment plants in Michigan and other states. And so as these conflicts, these types of conflicts increase in potential frequency or severity, these types of hybrid warfare, asymmetrical attacks may occur in the United States. We know it's certainly a game plan for if we, heaven forbid, were ever to get involved in a conflict with China, that would probably be one of the, or over Taiwan. It wouldn't necessarily be directly with China, but over Taiwan, that would be one of their first methods of action, is to actually attack our critical infrastructure with cyber attacks. And we probably would do the same over there. But these can cause significant disruptions as well as problems in the healthcare sector, because we know that critical infrastructure that's attacked, such as water treatment plants or power plants or nuclear power plants, if those are attacked, they have cascading failures that can impact hospitals as well as public health, and then ultimately society. So now I've talked a lot about the, kind of threat and the problems, and now we're going to talk a little bit more about sort of the solutions. But before we do that, we have to understand the mindset, because often when we look at these types of things, we think of, okay, what are the solutions? If the solutions were simple, if it were simply about increasing our defense, then it probably already would have been done. So we need to kind of move away from this offense-defense mindset, because this truly is asymmetrical conflict. You're dealing with intelligent adversaries that are motivated and usually very well financed, very well resourced. And as a defender, you have to be right 100% of the time with 100% of your systems. The offenders really only need to find one vulnerability, It doesn't mean we don't do good defense. We have to incorporate that, but we can't just rely on our IT individuals and our clinical engineers and the federal government or the state government to try and help us in this defense. It's impossible to do that. So what I like to sort of think about is this idea of cyber resilience. How do we become cyber resilient? Just like with any type of a disaster. And this starts with individual resilience. And that's what we're doing to some extent on this talk. But how do we educate ourselves and begin to have good cyber hygiene practices? And then we can extrapolate that and begin to sort of expand it out to our organization. So is our organization working towards overall cyber resilience, and how are they doing that? Again, it's not just about perfect defense, but how does the organization actually achieve some element of cyber resilience? And then once organizations have become cyber resilient or are working on, they don't have to be perfectly cyber resilient, obviously, but then is our community cooperating, coordinating to be more cyber resilient as a community? Because again, that cyber blast radius and those care vacuums can occur almost instantaneously with with a ransomware attack. And then regionally, that's sort of the next step. How do we regionally become cyber resilient? And then if you want to talk about sort of on a state or on a national level, that becomes much more of like a homeland security issue. And then we have to think about some basics. So to become cyber resilient, we have to have a basic understanding of cybersecurity. And this is a very kind of simple concept that is one of the most fundamental concepts in cybersecurity, and it's called the CIA triad. It has nothing to do with the Central Intelligence Agency, but it is about protecting your digital assets. And this can be applied on the personal level all the way up to the regional level. So how do we protect our digital assets? Well, the C stands for confidentiality. We need to maintain how do we do our best to maintain the confidentiality of the information? So that only the people that are allowed to see that information or have authority to see that information are allowed to see it. A confidentiality attack or an attack on confidentiality would be something like a data breach, like the Anthem data breach, where they steal the information, they're unauthorized, and then they steal the information. The second side is integrity, and that is making sure that our data is trustworthy across time and that we can rely on the data that we're looking at. So if you think about an integrity attack, that is like that session hijacking that we looked at with the CT scan being changed from what looks like a typical sort of post care CT scan to one that has been altered to look like it has metastatic cancer. That's an integrity attack. And then availability is the third side of the triad. And this is about making sure that the people that need the information are able to access the information when they need it and how they need it. And so an attack on availability is a ransomware attack where they encrypt your systems and no longer allow you to have that data available to make decisions. If you can guard those three sides of your digital assets, then you're well on your way to a good cybersecurity posture. However, those are not the only components of good cybersecurity, but they are a really fundamental concept that I like to talk about so that people can understand this and begin to employ that. And then we need to think about under our clinical workflows. So again, if we have some understanding of cybersecurity, the next thing we need to think of specifically from clinician perspective is how do we analyze and understand our clinical workflows and guard those clinical workflows. And this starts all the way from the pre-hospital and the outpatient clinics all the way through the emergency departments, radiology, pathology, inpatient services, surgical services, rehab services, discharge and post-discharge services. All of these things in some way, shape, or form have multiple workflows that touch digital systems. In fact, at this point in history, pretty much all of these touch digital systems. So how do we map those clinical workflows and begin to understand where our vulnerabilities are and how we can create efficient workarounds in case those workflows are disrupted? And as a disaster medicine person, I often conceptualize these in two different frameworks. The first is the disaster cycle, which it's also called the emergency management cycle. But this is sort of a framework that we look at these complex problems and we begin with mitigation, and it kind of flows into preparation and then sort of response to the disaster and recovery from the disaster that then feeds into our mitigation priorities, and this is an ongoing cycle. And then the second framework I like to think about is the 4 S's. So staff and space and stuff and our systems. How do we begin to optimize all 4 components of the staff, space, stuff, systems framework to deal with this problem? So in the next few slides, we're going to go over the disaster medicine or the disaster cycle and talk a little bit about sort of the 4 S's and how we can approach this very complex problem. So in the mitigation phase, I look at this and I sort of think of this in 2 different buckets. The first is technical mitigation, and the second is administrative mitigation. And so the first 3 or 4 things up there: patching software, network management, multi-factor authentication, virus scanners, and firewalls, those tend to fall on our IT colleagues or clinical engineering colleagues, and they make up a good portion of the technical sort of mitigation strategies. The other things like supply chain management, supply chain security, physical security, so making sure that areas that that only authorized people are allowed into certain areas, and then beginning education initiatives. Those often fall more in the administrative side of the mitigation framework. And because we can't mitigate everything all simultaneously and understand or begin to work on, we can work in multiple different areas, but often we have to sort of risk stratify these mitigation priorities. So we have to think about what are our threats, what are our vulnerabilities, and what is our resilience. And so this is what's called a risk matrix. People have probably seen this before. It really is looking at your likelihood times your impact. So if you have a severe impact on something and it's very likely, then you're going to be over on the right upper part of this risk matrix, and you're going to have a very high threat. If you have something that's kind of a negligible or minor impact and it's unlikely or very unlikely to occur, then again, that threat probably should go to the bottom of your risk stratification priorities. And so as we think about the risk of cyber attacks, one of the biggest risks that we run into, unfortunately, is human error. Many studies have shown that despite all of our technical mitigation strategies, probably one of the biggest risks that we have is human error. And so those administrative mitigation priorities become very, very important, as well as the education priorities. And this becomes sort of a holistic concept. You have to get buy-in from all of the people that are in the organization to do the best they can to try and mitigate these risks. Is it going to be perfect? Absolutely not. But if we have good buy-in and create a culture of security at an organization, that can go a long way to mitigating those risks. Again, we can't prevent them 100%, but we can begin to mitigate them. So I would encourage, there are many, we could talk about sort of a culture of security and sort of how we can form that, but that would be an entirely different topic, excuse me. That would be an entirely different topic. But I would encourage you to begin sort of looking at how your organization can create a culture of security to minimize these types of risks. In terms of the preparation side, this is really about cyber risk assessments, making sure that you're incorporating cyber into your emergency operation procedures. Again, that workflow analysis we talked about. Cyber disaster training. This is a picture of us actually doing a functional exercise. I'll talk about the data on that in just a minute. But this is a cybersecurity functional exercise, ransomware exercise that we did with some residents. And then regional cyber exercises or even organizational cyber exercises are very important. So, for example, at Atrium Health, we have a cyber exercise that we do. And while I was at Indiana University, we were doing regional cyber tabletops in conjunction with the FBI and the Cybersecurity Infrastructure Security Agency and DHS. And several other agencies as well. So thinking about how to organize those things and understand how to make your region and your organization the most resilient it can be. So in the cybersecurity functional exercise, do these things actually work? How do we train individuals to respond to ransomware? Well, this is what we did is create a simulated ransomware attack, and then we tasked the learners with creating workflows as they were having to treat increasingly complex patients. And what we found is that before doing the exercise, there was very limited, if almost no knowledge of healthcare cybersecurity and how to address ransomware events after the exercise. You can see that that went up. And again, it's not perfect, but certainly the learners felt quite a bit more comfortable in recognizing some of the issues surrounding this, as well as how to safely take care of patients during this type of an event. In the response phase, heaven forbid, if you ever are attacked, the first thing is containment. And this is where this is almost always going to be on an IT side, but that may sound simple. Containment basically means shut everything down. It means to try and stop the spread of the malware. And so they will often shut as many systems down as they think are necessary. And that could include virtually all digital systems. So containment is going to be your first priority. The next is switching to manual clinical processes, and then coming up with effective information sharing strategies. And then all of this really is about making sure that you have continuity of clinical operations and business operations. Again, this goes back to that staff space stuff systems. So do you have enough staff? Do you have staff designated to do specific roles? For example, you may no longer have the ability to tube specimens over to the lab. Do you have runners? Your fax machines, or excuse me, your computers are going to be down. So do you have fax machines that are running on landlines, or do you have individuals that are going to be tasked with going over to lab and radiology and pulling reports? Do your radiologists know how to get how to communicate results of critical findings to the clinicians that are taking care of the patients? Do you have the paper charting, the prescription pads, the follow-up forms? And then one thing most people don't think about is how do you communicate with your colleagues in this situation? If your primary method of communication is with Epic Chat and you no longer have access to Epic, how are you getting a hold of individuals? You can overhead page, which is fine, but again, overhead paging only allows somebody to know that they're wanted in a certain area or to call a certain number. Do you have phones that actually function? Because much of our infrastructure is now voice over IP that may be taken offline during a cyber attack. So these are, again, I don't have solutions for everybody, but these are problems that individual organizations need to address because everybody has different processes, even if they are similar. And then on the recovery side, again, recovery occurs simultaneous to the response. This is about quickly and efficiently relaunching your digital systems, integrating your manual processes and all of that information back into those digital systems. So hopefully, not only do you have the ability to write notes, but you have an ability to organize those notes and then make sure that you can retrieve those notes and reintegrate them back into the digital system. Ultimately, you want to evaluate for future mitigation priorities. That includes structured debriefs with your departments. And then from a legal perspective, making sure that you are collecting attack forensics, again, pretty far out of the scope of any clinical responsibilities. So that gives us a framework to begin approaching solutions to this problem. Again, if there was a simple solution, if it were, one size fits all, it wouldn't be really, it'd be pretty easy. Somebody would have done that already. But it really is a whole organizational effort. And really, it ends up being a whole community or even a whole regional effort. And so as we move forward, there are several things that I like to talk about because technology is advancing so fast. And even just in the past 2 to 3 years, we've seen so many changes and so many advancements that sometimes the solutions of the past are just being outpaced by the problems that are being brought forward by some of these advancements in technology. So for example, AI. Most people really weren't using AI at least they weren't consciously using AI on a regular basis 3 or 4 years ago. And now everybody's using it for all different types of problems, including on the cyber offensive and cyber defensive side. With the advent of things like Claude Mythos, and if you're not familiar with that, it's a very interesting but also somewhat terrifying AI. The cyber defenders are given an incredible tool, but so are the threat actors. This type of technology can find vulnerabilities amazingly fast that nobody even knew about. So how are we going to leverage things like AI? The other thing that we're starting to see is agentics become more and more of a process. They're starting to not necessarily replace individuals, but certainly augment a lot of our decision making and processes and tasks. How do we how do we utilize agentic AI and to mitigate our risks and potentially respond to problems, but also how does agentic AI itself create its own threat landscape, its own attack surface? That's something that really hasn't been worked out yet. This is, again, these are brand new technologies that are coming online, and we're beginning to utilize them, I think, without entirely understanding some of the risks. I have an entirely different talk about sort of agentic AI and the risks associated with it. With advanced robotics and quantum computing, we don't, I think that's going to change just the nature of technology in general, and we're already seeing that. And then overall, across the world, there's an increase in digitalization of healthcare and access to digital technologies. So as digital technologies get into every corner of the world, that's going to allow people amazing resources, but it's also going to allow threat actors to more easily access these types of systems. And this is something that I sort of had AI create, so don't blame me if it's bad, but it basically is just an idea of sort of a cyber resilient framework. So again, we're dealing with a wicked problem that's very challenging. So how do we integrate all of our different services, clinical services, non-clinical services, into some type of a resilient framework, including all of our, emergency department, radiology, pathology, surgical services, inpatient and outpatient services. I would definitely include EMS on there, or public health, emergency management, and then all of our different individuals, all the way from physicians and clinicians and nurses, all the way down through our administrators, through our leadership, IT, our physical security. All of those people need to be involved so that we can achieve the best resilience that we can. And ultimately, with this type of a talk, I'm hoping to sort of open people's eyes and their minds to the possibilities and how they can begin to get involved in this. Because I suspect that many people on this talk are probably clinicians, although I don't know that for sure. But we often don't speak cyber. We want to take care of patients. We want to do what we do, what we're trained to do. But unfortunately, many of our IT and clinical engineering people don't necessarily speak clinical. And so we need to become that bridge. People need to start bridging that divide, because ultimately it's about caring for the patients. And during a cyber attack, it will be the nurse and the doctor and the paramedic and the individuals on the front line that will have to still take care of that patient, but they're going to need all of the resources brought to bear by the IT team and the administrators to do this as efficiently and effectively and as safely as possible. Because at the end of the day, when the worst thing happens and you're faced with a crisis like a natural disaster or an intentional attack, it's really about trying to maintain care in the best way possible. So thank you very much. That's pretty much all I have. Here are some resources if you want to learn more. CISA has some really good resources. That's the Cybersecurity Infrastructure and Security Agency, which is part of Department of Homeland Security. Of course, the FBI has several resources on law enforcement. And then ASPR Tracy, which is part of the Department of Health and Human Services, has some really, really good resources. If you want to become very educated, I would recommend ASPR Tracy from a healthcare and clinical perspective. So thank you very much. And if you have any questions, I'm happy to talk more.
Brian, thanks. That was fascinating and more than a little bit terrifying. I'm kind of curious, and maybe this is maybe it's a loaded question, but it's hard to even ask if we're ready for something like this because we don't even really know what's coming. Like you said, these are just coming online. How do we assess the threat? Are we essentially all on our own island and every organization is just going to have to defend these on their own? Is there some sort of, you made the point, don't wait for the government, obviously, but, I just think of Epic and Haiku and all these things that we use. Are we all just doing the best we can to figure this out? Is there some poor person in our IT department that is our defenseman? I mean, what sort of organizational type activities do hospitals of this size and the other ones that are online have in place currently?
That's a good question. And it really depends. And it's really varied. So I've worked in several different health organizations, and some are very aware and preparing. Some are not. They're just not terribly aware of this, or they don't have a really good plan in place. I would say that no matter where you go, one place to start is sort of with your emergency management team, as well as from a clinical perspective, sort of taking the initiative to sort of look at this. Again, the problem with, in my opinion, is that it's not just a clinical problem. This is an operations problem. This is a systems problem. And so individual organizations can begin to start working on that resilience. And what does that look like? Well, I would break it down into some really pretty simple things. The first is like, how do we identify our mitigation priorities and how do we prepare? If you can get those two things started, I think that's going to be a huge win. And then beyond that, once we simultaneously, is how do we coordinate with other departments and then other organizations? So when I was in Indiana, we had these annual regional tabletop exercises where we brought in everybody. We brought in all the health systems, EMS, I think the police were there, fire departments, federal government, the utility companies, all of them were there, and we would go through these huge scenarios. We do about a half a day to a day, and we talk through it, and we do breakouts. And a lot of this, with just like any disaster, is about who you know. So I'm relatively new here in North Carolina, but if we can start forming those relationships and having those contacts, it's going to be much easier in the setting of a cyber attack or any other disaster where we can respond to those.
Dr.
See Thomas
Thomas.
Bradley.
Hey, Ryan, that was a great talk. I have a question kind of on the flip side of what you covered, as far as, you showed all the disruptions and very nicely with these attacks. I was curious if anyone's really looked at, the inadvertent effect of security hardening and when that impacts care, when it breaks things, trying to prevent something from happening.
I haven't seen, that's a really interesting question. I haven't seen a study on that. I imagine that's probably somewhat challenging to do. Although, there's always that pushback, especially when you start getting into, different MFA and, firewalls. I've sat on several cybersecurity or business continuity committees in different organizations. And there's always that discussion like, hey, we are going to have a pretty hard firewall. And then people start to work around it some other way, And then there's other organizations where it's kind of like, we don't have much of a firewall. We're not going to put any policy. So I don't know of any studies. I can't tell you any off the top of my head. And I don't know if there are true clinical impacts. I think they're more of, from what I've heard, this is just sort of anecdotal, they're more of, I guess, wellness impacts. People get very frustrated and they don't want to do it. So there's this idea of friction. I don't know if you've heard of that. Sort of this idea of friction, like there's this right amount of friction that an organization can have administratively and technically. And if they overdo that friction, then what ends up happening is people start finding workarounds or they just stop doing the process. Whereas if the friction isn't high enough, then it doesn't actually create any security barrier.
Mr. Peterson.
Yes, sir. Thank you. So speaking from the emergency management side, and I know we've got a lot of folks on here from obviously Atrium, and there could be others on here. I know with this being a more regional lecture series. However, so I know most emergency management groups within facilities, there have been opportunities to answer your question that you had a minute ago in reference to the state has provided some exercises. We have participated in those as well as some leadership have, I know from the Charlotte area here, in exercises with the state that involved not only the FBI and CISA and those other groups, but also the National Guard. So North Carolina National Guard has a large cyber response group that does respond to, I guess you would say, citizen incidents that occur within, especially the healthcare organization. So we do exercise locally with our partners. As Dr. Hata was saying, that relationship is huge. We have direct contacts with the FBI agents here in the Charlotte area and speak to them on a regular basis. And then furthermore, from a preparedness effort, I know speaking on behalf of the Atrium side, here in Charlotte, we've conducted 17 cybersecurity 7-hour exercises since April, and we finished up with CMC about 2 weeks ago. Each one of those had roughly 40 leadership positions in there, from obviously administration all the way down to supervisory level, had clinicians in there, had some nurses in there, and we ran cybersecurity exercises on two different scenarios. So the learnings from those have gone up to enterprise level, and everyone obviously within Atrium is going to be seeing a lot of mini exercises come out around utilization of the BCA computers that are located in every service line and floor, as well as some other stuff to basically what Dr. Hata was saying, harden our infrastructure a little bit better and hardwire what that response looks like. Because as you all spoke earlier, it's not an emergency department issue. It's not an administration issue. When we've had these issues such as CrowdStrike and others where we've been cut off from the network, I guess you would say, it is totally a full facility experience. So really trying to hardwire some of that response all the way down to our frontline teammates.
Yeah, that's great.
Thanks for, yeah, go ahead, Ryan.
I totally agree. I think, getting that response down to the front line is so key, and just all the way up the chain of command. And it's challenging. I mean, with an organization like Advocate, you have hospitals all over different regions that are, not necessarily connected, yet they are, obviously part of a bigger system. And so it really is this sort of, there's a balance between, how we make sure that each individual facility is adequately prepared and can respond, but also how does an enterprise, a large enterprise, address this from a more global scale. But that's really great.
I want to put one of our participants on the spot, if I can. Our former trauma and critical care fellow, Dr. Jennifer Meisenheimer, is joining us from her practice now outside of Dallas, Texas. So I know that she has some firsthand experience with this recently. Jen, you want to comment or make any questions? Great to have you with us
Yeah,
from Texas.
thank you guys for having me. That was an excellent talk, and one that I really didn't think about until you're on this end of things. About 3 weeks ago, I guess now, our practice here in Fort Worth, Texas, at a level 1 trauma center had some suspicious activity. And so they emergency shut down every, computer system, Epic. I was actually on call when everything just went down. And it's a very vulnerable feeling because you don't have any instruction, and I didn't have the foresight to kind of think through some of the processes that were in place or ask questions about whether there were processes in place. And as has been mentioned, it's a system-wide issue. And for me, the ultimate thing is taking good care of patients. And you felt very vulnerable because felt like you couldn't do that. For example, our lab did not have the ability, nor did it have the manpower to process all of the labs. So I guess as it stands now, the blood goes to the lab and it runs through the machine and auto-populates into Epic. Well, when Epic is down, you take the work of one machine and suddenly you need 50 people to try and get all of these labs resulted and faxed over, called over, printed to all the patient charts. And so having the understanding that this is a real possibility for any hospital system in the country, even if you don't think it's going to happen to you, and understanding of the downtime processes that are in place and doing the trainings, I just think is hugely invaluable. So thank you for bringing this topic to our attention, because it is definitely, I fear, going to be growing in how common it is across the country. So excellent talk. Thank you for letting me join.
Thank you so much. One thing, if I could say one thing, to do, if you have one take home point, is find that, old, no, I shouldn't say old, but the experienced like doctor, clinician, nurse, whoever that worked back before there was electronic health records and physician order entry, and they're becoming incredibly, less common now, and that institutional knowledge is going away. And that's actually really unfortunate because as that institutional knowledge leaves, we don't really have a reserve. We don't have it's you're having to figure it out from scratch. But if you can tap into those individuals and begin mapping out those clinical workflows, how did you do it back, when there wasn't EHR, when we were doing all, and this is, so when I started my, medical career a while ago, we were, using whiteboards and paper charts and paper everything. And so I still have that knowledge. Now you can obviously tweak it to your own institution and your own department, but creating that process, and then again, it goes back to your sort of staff space stuff systems. So go to those four S's, like what staff do you think you need? What stuff do you think you'll need? How do you acquire it? What space do you need to actually store the stuff and to have that equipment? And then what are the systems that you're going to have to use, and how are you going to, deploy your staff space and stuff to accomplish those systems? So that's sort of that sort of 4S disaster framework. And if you can access, the group of people that know how to do that and have that institutional knowledge, they can be invaluable.
Wow, you just made me feel incredibly old yet somehow valuable at the same time. Um, but terrific comments. Thanks, Jen, for being on. Any other comments or questions? We've got a great crowd. Obviously, piqued a lot of interest with this topic and very interesting stuff. I don't see any hands up. A little bit over time anyway, so we can go ahead and wrap it up. Ron, thanks again for bringing this to our attention. Just like Dr. Meisenheimer said, so many parts of this you just don't think about until all of a sudden it happens to you. So it's great to bring this to everybody's attention. And glad to know I can still do paper charting. Thanks everybody for joining us, and look forward to next month's conference. There'll be some information going out about it. It's going to be sort of focused on topics of rural trauma. So certainly hope we get a lot of people on board from outside the center city. Dr. Hata, thank you again. And thanks everybody for being part of it. Enjoy the rest of your day.
Thank you very much. And if people want to get a hold of me, want to talk more about this, again, always happy. If you want to try and set up your own, processes, can help you talk through them or walk through them. Thank you.